So I believe that if we're going to change healthcare in the United States, we're going to have to start by creating a new kind of healthcare provider, a transdisciplinary provider that sees in between and through disciplines. And to explain what I mean, I think we have to start by talking about what it means to be sick. So let me start by saying that I'm a nurse, and I work with nurses and doctors all the time. I'm also a lawyer, so you can take whatever you want from that. We have a great medical care system in the United States. It's really one of the best in the world. When you're sick, this is a great place to be. What we're terrible at is keeping you from getting sick in the first place. In fact, it's a badge of shame we wear among industrialized nations. And the reason this matters to transdisciplinary practice, I'm going to explain by way of a story. So in urban emergency departments, we have a plague of children with asthma who come to us in the emergency department over and over and over again. They come because they can't breathe. And when they get to us, we put on our differential diagnosis hat, and we sort of think there could be one of two things happening. One option is that these children have some sort of acute infection, right? There's some sort of respiratory ailment that's causing them to not breathe. The other is that they're not doing whatever it is we think they should be doing at home to keep their asthma under control. And the way we think about this differential diagnosis is due in large part because of the tools we have in the emergency department to fix them. So we can give them antibiotics, a nebulizer to make air go in and out to cure the infection, or we could educate them, put them in an exam room and say for the umpteenth time, every day do a peak flow test. Make sure you take your oral steroid, and then we treat them and street them. The problem is that childhood asthma isn't caused by not learning what you're supposed to do at home or by getting a rare infection. Childhood asthma, especially in dense urban areas and especially among the poor, is caused by the environment we have built. What I mean by this is that in kids who live in houses with mold and mildew, or who live in houses where there are rat and rodent feces and dander, or get this, in poor areas that are also violent, children who are afraid to leave home or whose parents won't let them because it's dangerous spend more time indoors around indoor air toxins and wait for it. This is the punchline. Their asthma flares up. So the real question is, why is it that we're still giving them medicine and telling them to use peak flow meters? Well, the answer is, in part, that we have yet to take serious the social determinants of health. This is the stuff that actually makes us sick. And there are a lot of people who are a lot smarter than me who have talked about this all over the world. So I'm not going to do that here, but suffice it to say that we must pay attention to these social determinants of health if we're really interested in healthcare. The challenge is, and I'm letting you in on a little secret, it's like looking behind at the kitchen of your favorite restaurant, so I'm sorry to do this to you, is that nurses and doctors, we're not trained to do this at all. We have no idea how to do this. So what we have to do is make a new sort of provider. And to think about it, I want to talk about the evolution of healthcare providers. Now, this is a bad analogy, so I want to apologize in advance to any evolutionary biologists in the audience who are going to say this is a terrible analogy. If you consider that at first, we realized that siloed healthcare practice wouldn't solve the social determinants of illness, right? So a physician sitting in the exam room, she can't figure this out alone. So we started getting multidisciplinary teams together, right? And doctors and nurses started talking. That was kind of the first one. That's a big deal. And then we added people like public health practitioners, and we got together and we realized that if we really put our heads together as a team, we could start solving problems. And these teams looked like us going in like a meeting, and we'd sit around a table, we'd have some water, maybe some coffee, and we'd say, well, as a nurse, let me tell you my perspective on things, right? And someone else would say something, and we'd come up with some solutions. Now, this was good. This was critical. And if we use our evolutionary model, which, again, not the best, this is sort of like Cro-Magnon man, right? So maybe not as evolved as the two to the left here, but we know he's got a long way to go because there's a lot of white space on this slide, right? And he's got that little tool right? That's got to be good for something, maybe making a fire or beating some sort of animal for food. So then we said, well, if 2 or 3 people around a table is good, what if we got a lot of people together? And what if we started getting strange people at the table, like lawyers? So through programs like the Medical Legal Partnership right here with the Indiana Health Advocacy Coalition, Eskenazi Health, the Neighborhood Christian Legal Clinic, Indiana Legal Services, we're now putting lawyers in exam rooms. Because sometimes when the kid with asthma comes to the ED, what they need is legal care. They need someone to remind landlords that it is in fact against the law to not abate rodents. That you cannot discriminate on someone based on what you perceive to be their immigration status and therefore not fix their house. And guess what? We see asthma improving. We see it being cured. And it's not just lawyers. In fact, that's a sentence that almost seems like it doesn't need to be said. Of course, it's not just lawyers. It's people like urban farmers, the community investment folks like you heard about earlier today, who are starting to realize that the things they do right can do health. So multidisciplinary teams are great, and they're making a big difference. So the problem is that I don't believe that we're fully actualized here. So if these multidisciplinary teams are more like this guy. He's standing upright, he has a stick, you can go get fish, whatever. He's even got sort of a hipster beard thing happening, which is nice. But there's probably room to improve, and I believe that room is through transdisciplinary practice. And this is what Piaget described as really seeing through disciplines. It really doesn't make a lot of sense to think about the practice of medicine anymore, or the practice of nursing anymore, or the practice of social work anymore. Not that we don't need those folks, we do. But what we really need are healthcare providers. And healthcare providers right now, they don't so much exist. And my good friend Brandon, a long time ago, made a comment on stage he probably forgot, and I'm going to tell you what he said, is that this is something like healthcare magic. And I'm not foolish enough to think this will change the world. It won't. But I know for a fact, and the evidence demonstrates, this will improve healthcare. So what does transdisciplinary practice look like? Well, for my bad analogy purposes, it looks like this guy. Heavily waxed. What it looks like is, and I'm going to tell you a story. This is a story about a physician and a lawyer that worked together in one of these multidisciplinary teams. And that they were dealing with this child, this pediatric patient, who was about to be expelled from school. And this expulsion would cause significant health consequences, and it wasn't warranted. But the lawyer wasn't allowed to go to whatever hearing it was for this kid's expulsion. So do you know what the doctor said? I can do that. I've worked with you for so long, lawyer here. I know how to advocate for patients the way you do. And so this doctor went in and did it. And the medical care she rendered looked a lot like the practice of law. Transdisciplinary practice at an organizational level is what we're seeing in healthcare right now. You may have noticed hospitals are getting smaller. Soon they're just going to be giant emergency departments with ICUs on top. And hospitals are going to have to think differently about what it means to provide healthcare. It won't be long before we see the Indiana University Health grocery store. And why is that? Because if you're trying to make people healthy, especially in urban food deserts, you've got to make sure they have food. This is not rocket science, but it challenges every structure we have in professional healthcare education. We don't think this way. So what's the solution? One is to start by realizing that lots of people doing lots of things are in fact practicing healthcare. There are people right now mining the Twitter and Google API, matching it to IP addresses to predict when outbreaks of diseases will occur. When you type in, "how do I fix a cough" on Google, these folks, by the way, who are not epidemiologists, many have no formal public health training, are saying, aha, that's where the next person gets sick, and I'm here to tell you it works. These people and those technologies are so disruptive, they've only been around a few years. I think we'll know when this works for real when maybe in 10 years' time at the TEDx after party, we're at the cocktail reception, and I go up to some of these performers, like Time for Three, and I say to them, "So what's the business you're in?" And they look at me, maybe with hope, and they say, "We're in the business of healthcare." Thanks.